Without wasting time, may I request chairperson for today's session, Dr. Audrey. She needs no introduction. She's a prolific cornea and cataract surgeon from Seattle, and we have a very powerful ophthalmologist with us. She is within a most influential 100 women ophthalmologists and also a powerful ophthalmologist of the world. And she is going to talk about cornea, cataract in the corneal diseases, and she's, I think, the right person to talk about it because she practices both the things, and she's an outstanding surgeon. So I request Dr. Audrey to start her presentation.
No, not just. This is the wrong session, I think. It's the wrong session. (11 to 12). No. Yeah, this one. Yeah, that. Sorry for the IT trouble. Yeah. Yeah. Perfect. Great. Thank you so much. It's such a joy to be here and to be in an in-person meeting rather than just on Zoom. I'm going to be discussing cataract surgery and corneal diseases and improving outcomes. Oh, sorry. Excuse me. These are my financial disclosures. None are relevant to the presentation. So what do patients want? Well, it's actually very basic. Next right here. Thank you. Patients want great outcomes and safe procedures, the same thing that surgeons want, and so we're all on the same page with that. What about patients with corneal disease? Just because a patient has corneal disease does not mean that they don't deserve a good refractive outcome. They may not be idealized as somebody without corneal disease. However, they still deserve the best refractive outcome possible. It's not just enough to have an anatomic success. We should have a visual success as well. Taking patients with keratoconus, for example, when we address patients who have keratoconus and do cataract surgery, one of the main things is to also address patient expectations. You want to look at the topography and tomography, take a look at the cataract, the density of the cataract. Usually we do the cataract surgery first, but there are cases where in a younger patient you may cross-link the patient first. And it's also reasonable to consider a toric lens. Now, how do you decide? I get patients sent to me all the time, and they have keratoconus, and so people are asking, when should we do cross-linking? You know, when should we do cataract surgery? And I would say that if the patient has mild keratoconus, there isn't, or even moderate keratoconus without documented progression, you can easily do the cataract surgery first. However, if you have a very difficult refraction, you're not getting good K readings, then you could do cross-linking first. Cross-linking to stabilize the cornea, but also to get a little flattening. Reasons for treating older patients with cross-linking? Of course, it's to prevent progression. You can still have progression in older patients, but it's also to improve irregular astigmatism and obtain more consistent K readings. This can allow you to decrease or flatten the K readings to allow a better contact or spectacle-corrected vision. This is an example of a patient of mine, a 60-year-old, yes, 60, with keratoconus and had documented progression when I saw them a year later. Another patient, 47 years old, again, here was the initial tomography. The second is this is progression before cross-linking, and this is about 9 months post-cross-linking, and you could see that there was, in fact, a flattening effect. Well, what about toric lenses? How do we decide what kind of toric lens to place? Toric lenses are possible to reduce cylinder in keratoconus patients with cataracts. They will not eliminate the cylinder, but we can certainly give them an improved outcome. IOL formulas are very important. The Kane formula is a newer formula that I think is very helpful for keratoconus. You also want to plan on some myopia. I usually aim for about a -1 to a -2, and you of course need to set expectations. The Barrett-Truquet formula and some of the other formulas that we commonly use, I find have a little bit more variable results. Let's see here. There we go. IOL marking for toric lenses, even if they have previous intrastromal corneal ring segments, you can still get a good result with a toric lens. And this is an example of placing manual toric marks there on the cornea. Very, very easy to do. You really do not have to and should not consider removing the ring segments and can again use toric lenses. How about ocular surface disease? Well, we all know, we all see patients with pterygia, basement membrane disease, dry eye, Salzmann's, and of course, we want to optimize the ocular surface first. You can see here in the pennicam below and the clinical figure above, this is a patient with Salzmann's disease, has a Salzmann's nodule, and you can see right there, very similar to when you have a pterygium, that area of flattening. So this is important to optimize before you consider cataract surgery on the patient. With pterygia, I usually wait about 6 to 12 weeks after excision, and I do a pterygium excision with a conj graft, and then I wait 6 to 12 weeks and then perform my biometry. If it looks a little funny, you can always keep up dry eye treatment afterwards, which all pterygia patients should have anyway, and then repeat the biometry. With basement membrane disease, Salzmann's nodules, I perform a superficial keratectomy, peel off the nodules, get rid of the offending basement membrane disease, wait 4 to 6 weeks, and again perform biometry. For people who don't think that dry eye matters, here's an example. This is a patient who had previous LASIK and had dry eye disease, and you could see that if I went with the IOL that I calculated before several weeks of dry eye disease, I would have implanted the wrong lens implant. So dry eye disease matters. Astigmatism. You need to look at the astigmatism and decide, is it regular or irregular? Even with some cases of irregular astigmatism, such as keratoconus, for example, you can still obtain a good result with a toric lens. Sometimes, though, it's too irregular, and then a toric lens is not going to give you what you want. The usual rules with astigmatism apply. Undercorrect with the rule, fully or overcorrect against the rule, and also remember about posterior corneal astigmatism. Well, if we're going to talk about astigmatism, we need to know how to measure it. I say to choose more than one diagnostic method, be consistent, compare your readings, and again, of course, if there's corneal pathology or ocular surface disease, read that, address that first, and repeat the readings. There's all kinds of devices, diagnostics that you can use to measure astigmatism. In my own practice, I have an IOL Master 700. I also have a Pennicam and a Cassini, and I actually use all three devices. You need to make sure you mark the axis, and there's a whole variety of ways you can mark the axis. Manual marking, you can use digital marking, you can use intraoperative aberrometry, which I have found to be a bit less useful, and femtosecond laser. I have a LENSAR laser, and with the LENSAR laser, I really like it because you can get these nice little custom capsulotomy with little notches or nubs in the capsule. You could see here that for a standard toric lens, it will easily align. Even in a case, for example, of a toric lens with a lens coloboma, and the reason for those crisscrosses is because it is a denser cataract. And also in the case of RK, I routinely put toric lenses in RK patients. When it comes to astigmatism, again, optimize the cornea before the cataract surgery, choose at least 2 pre-op diagnostics, undercorrect with the rule, fully or overcorrect against the rule, mark the axis, align the IOL, and if you do have IOL rotation, then I wait 2 to 3 weeks before realigning. What about cataract surgery with endothelial compromise? Well, this could be patients with previous full thickness PKs, previous DMEX or DSEX, Fuchs dystrophy, or other posterior dystrophies. And the question also comes up, do you do a combined procedure? Do you do the cataract first? Do you do DMEC or DSEC first? And I think that you, again, just like with keratoconus, you need to really evaluate the whole patient. You need to take into many considerations. If the patient is at or above the age of about 50, all of the literature shows that you should really consider a combined procedure because chances are they're going to need that cataract out within a year or two. If there's just guttata or corneal edema greater than the cataract, you can do, I like doing a DMEC on these patients, usually a younger patient. You can get a nice result with a DMEC and then proceed with cataract surgery later. And if there's, of course, not too much endothelial compromise, you can consider cataract surgery first. In the case of other corneal opacities, dystrophies and such, I really like to try to do my transplant first. If it's a full thickness or a DALK, I will do that first for improved visualization and improved K readings. When you get to doing the cataract, you'll get a much greater accuracy of IOL calculations and actual versus estimated K readings. Let's see here if, oh, there was a video there. Here we go. This is femtosecond laser-assisted cataract surgery following a cornea transplant, and as you could see by the pattern, this was actually a very dense lens. I use a dispersive viscoelastic to protect the endothelium. I do aggressive hydrodissection and hydrodelineation. You could see the bubbles there from the OVD that I used from the dispersive, and I use a soft shell technique for that. The nice thing about the femtosecond laser is that it basically pre-chops your cataract, and therefore removal becomes much, much easier. Let's see if this video will work. That video doesn't appear to be working. There we go. Now it is. Okay, this is a patient again with a less dense cataract. This was following a cornea transplant, at least a year later because I like all sutures removed. Again, I do a soft shell technique, and for this patient who had a significant amount of astigmatism, you can see the corneal relaxing incisions that I placed with the femtosecond laser. You could also do this manually if you don't have a femtosecond laser. There I am aligning a toric lens, aligns really, really nicely, again, with the corneal relaxing incisions with a transplant. We know that corneal endothelial loss following femtosecond laser-assisted cataract surgery, there is a decrease in the endothelial cell loss, and that's a really nice thing if you have that available. It actually causes less corneal edema in the early postoperative phase, and again, less endothelial cell loss, which is really helpful for patients with either endothelial disease or with a previous transplant. What about cataract surgery with refractive patients with previous refractive surgery? Well, once a refractive patient, always a refractive patient. So these patients have very, very high expectations. Patients with, we're seeing more and more patients who previously had ICLs, phakic IOLs, patients with, of course, laser vision correction or RK. This is a patient who had ICL, and how I like to remove them, I know some people just orient them and pull them right out. I actually, just like a regular IOL, I just cut it, not apart, but I just make different cuts in it, and then I just twist it out. And again, the same sort of method used here with hydrodissection, hydrodelineation, use of additional dispersive viscoelastic. I always do a bimanual technique both for my phaco as well as my IA. And then you can place a toric lens or a EDOF lens or whatever you like there. In the case of a cornea transplant patient, I don't use any multifocal or EDOF technologies. Cataract surgery, of course, is refractive surgery. IOL calculations can be challenging. For my regular patients with previous refractive surgery, I tend to use the Barrett-Trouquet formula. I find that works best in my hands in my clinic. I like getting the ASCRS formula. That they give you a whole bunch of formulas, and you can take a look at that. The Kane formula, again, I really like for keratoconus. And of course, there's different IOL choices these days. One thing that's really important when you have a previous refractive surgery patient, especially someone who had LASIK or PRK, is I really like to look at the holiday report on the Penacam, looking at higher order aberrations and also chord length mu. Chord length mu relates to angle kappa. And if you see, and it's really nice because it's red, so it's red, stop, right? If you see a lot of higher order aberrations, as you can see here with a horizontal blue arrow, then you really do not want to put a multifocal or trifocal lens in that particular patient. Chances are they're going to be unhappy. You can use some of the EDOF technology. You can also consider an IC8 lens, the small aperture lens as well. Cataract surgery following RK, again, avoid the multifocal IOLs. You may need to suture the wound and or the previous RK incisions. Sometimes you have to do a scleral incision, and sometimes the incisions start to flap up, and it's a little bit exciting. The thing that's newest in my practice is I've started to use the light adjustable lens. The LAL can adjust up to 2 diopters of astigmatism and plus or minus 2 diopters of myopia or hyperopia. It works by having selective macromers, and you do these light treatments afterwards. And so you want to still get as close as you can to where you want to be, but the nice thing is you can really customize it to the patient afterwards. You get 4 shots on goal, essentially. You get 4 treatments. I aim for plano in the dominant eye, and you do get a little bit of an EDOF effect in the non-dominant eye by aiming for at least a -0.5. And it's really impressive. These patients actually get more range of vision than you would expect with just aiming for about a -0.5 refraction. So in summary, cataract surgery in patients with compromised corneas can still achieve good outcomes. You can provide refractive benefit for patients with corneal disease. Also make sure that both you and the patients are aware of the limitations. Address the corneal disease prior to cataract surgery when possible. There are newer IOL calculation formulas. Try them, see what works best in your hands, with your patient population. And there are opportunities for toric IOLs in patients with all kinds of previous corneal transplants. Thank you so much. It's been a pleasure.
Excellent presentation, Dr. Audrey. I would request Dr. Aditi to present first because she has session in some other hall. So Dr. Aditi is going to talk about how to detect, prevent, avoid, and manage complications while doing a pterygium surgery.
Thank you so much. At the outset, I would like to thank Dr. Somshila Murthy ma'am, Dr. Vineet Joshi, and Dr. Kavya Chandran for giving me this opportunity. So I'll try to keep it very short. So pterygium surgery, complications, how to avoid, identify, and manage. So it is basically, we are treating the tip of the iceberg. Excision is very simple. The main thing is what is beneath it, what all complications we can, get to do. I mean, we have to treat also. So pterygium surgery is one of the first surgeries that we get in our residency. It is very simple. It is our first exposure to ocular surface surgery. It has a fast surgical learning curve and has good outcome. So let's see a very simple case with sutures. So the excision of can be any way which is comfortable to you, whether you're using a simple blade, burr. Just be very clear that you are exposing it well, you are removing the tissue very properly, not excising excess of normal healthy conjunctival tissue, taking a good graft, sizing it properly, not taking any excess tenons tissue from the donor site. Try to make the graft as thin as possible because the uptake will be better as well. So here you can see Be very careful about the alignment of the graft. So when you can place it over the cornea, it depends, and you can just keep it on the side. So here we'll be using sutures. So just simple sutures, you can bury them or you can put a large diameter BCL on it. So this is a very simple case. So here are the results using a suture properly. So you can see the alignment of the graft is proper. It is not upside down. So why not upside down? You can see the marks. So we have to mark the graft properly, so that we can assess whether we have put it properly or not. We have to see the limbal, whether it is towards the limbus or not. These are very small points, but very helpful, especially in new surgeons. So now let's see if with fibrin glue, surgery has become even more easier. The surgery time has decreased. The learning curve has decreased. So here again, as I said, a very thin graft is very good. Take it, remove the excess tenons, do minimal cautery, not a lot of cautery as well. You can align it over the cornea. So here I've already flipped it. Put glue. Either you can put both on the donors on the site, or you can put one component on the graft under surface and one on the bare sclera. So here you're seeing we're making here, as you can see, it is a little bit oversized. So we are trimming the excess, flatten it, iron it properly with a muscle hook, so that the surface is very smooth. Don't keep any unnecessary irregularities. Cut, excise excess fibrin glue, don't pull it, because many times, we have a tendency of pulling the fibrin glue, and with that, the graft as well comes. So fibrin glue and suture, fibrin glue, as I told, the surgical time decreases, the residents are feeling good, the outcome is better. So now the complications. In spite of using glue and all, sometimes we can have graft dislocation. It can be an upside down graft. We can have a localized edema. It can be a generalized chemosis. It can get dehiscence, graft dehiscence can be there. Sometimes there can be underneath hemorrhage, which is not letting the graft oppose well. Or it can be a localized hematoma for which the patient is very much concerned due to cosmesis. So how to just divide the complications? It can be intra-op, so inadequate exposure. Be sure you're excising it well. You're seeing what you're excising. Inadequate excision of the tissue, leaving unwanted pterygium tissue just to wrap up the surgery fast. Inadequate hemostasis, corneal surface irregularity. Don't be hesitant. If you are very junior, you can do it under supervision. Make the cornea as regular as possible without damaging it, of course. And graft-related, size it, position it, secure it properly. Donor site has to be addressed. Some people, we use fibrin glue to secure it well. You can use sutures as well. Improper MMC use, I'll deal it later on. Or muscle damage, overzealous excision. You should not damage the medial rectus muscle. Post-op, main will be graft-related, recurrence, and scleral melt, and others also. So these graft complications I've already dealt. So how to prevent is mainly measure, properly mark, orient, position, align, and secure. Staining is a very simple post-op thing, but it helps you a lot. It makes you see not only the corneal epithelial defect, which is healing, but also the epithelialized conjunctival surface. So now when are adjuncts used? We all know conjunctival autograft is the best tissue, but there are conditions like in glaucoma patients when we want to conserve the bulbar conjunctiva, there's an extensive conjunctival involvement with multiple heads. So in these cases, we need adjuncts. So what will be the adjunct? Either just AMT or use of subconjunctival AMT along with a CAUG. So now studies show that this is better than just use of a plain AMG, which with lesser chances of recurrences. So let's have a video of this. So here's the surgery. I've removed the two heads. So now we have secured AMT very nicely over the whole surface. Here we'll take a CAUG, divide it, and put it on both the sides. So here you're seeing we're securing the AMT with the fibrin glue, ironing it properly. We have covered the corneal surface as well. And now from the CAUG, we are taking the simple graft only. Sorry, I should have fast forwarded a little bit. And from this only, we are dividing into two. Marking it so that, because they are very thin grafts, so you might lose them. So be very careful. When you're putting the graft, that time don't let anyone, drop something. Tell your assistant that, no, right now the graft is on the cornea. Please do not do anything. And just secure it. So this markings, you can see the markings, and you can see the graft over the AMG. and secure the donor site well with a fibrin glue. Put a large diameter BCL, and these are the post-op results. So recurrence, another nightmare. So why it occurs? It can be due to inadequate excision, leaving the limbus uncovered, a Bayes sclera technique, inadequate treatment. I'll not go to the details of it due to shortage of time. So intra-op MMC use is one of the adjunct we do a lot in recurrent cases. But excess time use of MMC can lead to further complications. So here's a case which was referred to us. They had already done a scleral patch graft for a melt post-pterygium. But as you can see, this was an ischemic scleral graft. The tenon was not over there. It was not vascularized. You can see the you will show as well. So we took a larger diameter scleral graft, thinned it a bit, put amniotic membrane. We tried to take out tenon's pedicle to cover it over the amniotic and then put a large amniotic. But there can be times when you'll not get this tenon pedicles at all. In that cases, you can do it on amniotic, but it is very good if you can give a vascular pedicle to such cases, because they heal very well. Okay, so now what else can happen? There can be pyogenic granulomas, tenon granulomas post-surgery. Easily they can be managed. First you can start with steroid. If not resolving, you can do an excision with amniotic. Epithelial inclusion cyst, you can remove it in toto. Infections. So many times we have an epithelial defect, a lot of steroids is being used in that. They can land up with ulcers. Be very careful, rule out infection before thinking of it as non-infective. Here's our case which has been shared by Dr. Aditya Pradhan. So this is a case post-pterygium excision which presented to him, and here we can see the sclera and the cornea is involved. So after he ruled out the microbial involvement, which was all negative, then he went ahead with a scleral patch graft along with the corneal patch graft for the corneal area as well. So here he will put an amniotic membrane over it, as opposed to like there I had some tenon pedicles, so I could cover my graft with the tenon pedicles. So here you can see he will do a therapeutic along with it. So as I said, excising the pterygium tissue is just the tip of iceberg, but we have to keep all these complications that can occur and cover it with an amniotic membrane. Cysts is one more complication that we have to deal with. It can occur due to a Bayes sclera, excessive use of cautery. Rule out infection always. That should be the main aim. And scarring, inadequate, again, removal of the corneal attachment. There can be a pre-existing scar. Pre-op, you can evaluate, do an ASOCT. It gives you a better idea. You can put amniotic membrane. If you're feeling it gives a better result. Here's a video. And don't be very scared of removing the adhesions. Don't try to leave behind the adhesion. Try to clear it as well. The technique depends on you, whether you want to scrape it off with a blade. Due to less time, I'm trying to forward it. Whether it is a hockey stick, it is your simple blade, or a diamond burr, whatever you are comfortable, which works good in your hands. That is the most important. Try to make the corneal surface as smooth as possible before closing the case. Post-op residual astigmatism, ma'am, is already dealt with. So we should wait for the cornea to stabilize 6 weeks plus. Contact lens trial are a boon in such cases. Surface ablations also people are doing. One more point I would like to highlight, do not forget the importance of histopathology, because there are sometimes we miss out on the masquerades. Like this case looking like a granuloma, but ending up as looking like an oassistant ending up as a granuloma post-pterygium excision, or a referred patient for a recurrent pterygium, but coming out as a CIN. I would like to, so the take-home message will be pterygium surgery complications. The good thing is they are predictable, preventable, and treatable. And of course, the good news are always when we detect them fast and treat them fast. I would like to thank Dr. Rishi Swaroop and Dr. Aditya Pradhan for sharing their cases and my institutions. Thank you so much.
Thank you, Dr. Aditi. Excellent presentation. Next is Dr. Aditya Pradhan, who is again going to talk on a very common problem, that is descemet detachment, how to prevent and how to manage descemet detachment. No need to introduce Dr. Aditya Pradhan. He is savior for all of us whenever we are in need of scientific articles and you just message him, and within 2 minutes you'll get any article in the world. And I'd really like to thank him for that.
Yeah, thank you, Swapnil, for the kind introduction. So, in the interest of time, I'll just skip and reach the videos. So, basically, we know that I have no financial interest to disclose. We know that this is a complication which has occurred to all of us as both cataract surgeons as well as dealt with it as cornea specialists. So, the risk factors, just briefly go through them. So, if you're dealing with older patients, those who are having denser cataracts, if the anesthesia is not adequate, the patient is continuously moving their eyeball, or a previous history of neovascularization or chemical injury. During the surgery, a clear or incision which is not adequate in size, it is too small, it is oblique or ragged because of blunt instrumentation, or manipulation through the ports, or the too much of ultrasound energy has been used. And sometimes spontaneous DMD can occur because of certain endothelial dystrophies like Fuchs and posterior polymorphous corneal dystrophy. So if you recognize any of these risk factors, you would be very well prepared while dealing with the patient on the operating table. So basically the patient would say that the vision has not improved much after the surgery, or it has even worsened compared to the pre-op. They may, if they are smart enough, they may say that the cornea has become white. They may experience a foreign body sensation and lots of watering. So on the slit lamp, you can see a translucent membrane in the anterior chamber if you make a fine enough slit. And there can be a localized or a diffuse corneal edema, which is generally treated for quite a long time as striate keratopathy, but sometimes there is a DMD lurking behind it. Or you can see a double anterior chamber as well. So the imaging tools, ASOCT is the gold standard. The management is either conservative or surgical, so I will be focusing on desmetopexy, or that is the injection of gases in the anterior chamber to reattach the DM. So conservative management, you can, if you are dealing with a small peripheral DMD with non-scrolled edges, sometimes non-planar DMDs may also respond, you have to just wait and watch. But surgical management, if there is a scrolled edge, the length is more than 2 millimeters, it is involving the visual axis, and those who are not improving with conservative therapy, you have to go for a definitive surgical intervention. So this is Susan Jacobs' classification of DMD, which is analogous to the vitreoretinal colleagues, in which there can be a tractional DMD or a rhegmatogenous or a bullous DMD, and the management varies as per the classification. So basically, this is the current gold standard of treatment. Air or isoexpansile gases like C3F8 or SF6. You have to use a micropore filter to inject this into the anterior chamber. So basically the steps are you have to first identify and locate where is the DMD, either through the slit lamp and also ASOCT if you have access to it. The paracentesis can be with a MVR blade or a 26 or a 30 gauge needle. The entry site has to be away from the DMD, not where the DMD is located and where the DM is actually attached. And you have to inject a single continuous bubble of gas. Keep the patient in that situation for at least 15 minutes. Reduce the air bubble to around 8 millimeters or so, and then don't forget where you made the entry, suture it. And if you intend to leave the patient with a complete limbus to limbus air fill or a gas fill, please do an inferior PI. Never inject forcefully into a sudden gush of air is not advisable, or especially where the DMD is located. Please be aware, if it's a patient referred to you, there may be some vitreous in the anterior chamber. Avoid multiple bubbles. A 1 ml syringe is more than enough. You don't need a high volume syringe. Just make the entry just to accommodate the cannula. There should be no leak. Always suture that. If you don't recognize there may be fluid or viscoelastic above the DMD will never resolve even if you inject whatever you want to. Make sure the IOL is stable before you push air into the anterior chamber, especially if it's a case not done by you or referred to you by any other colleague. So I'll just go to the cases now. So basically this was the case in which the phaco was done elsewhere with this diffuse keratopathy. The ASOCT has revealed this near total detachment. And this is the area in which you, on the ASOCT, where the DM is still attached. So this is the point of entry for you to inject the air. So the video is courtesy of Dr. Basak. So you must first make the entry sitting superiorly where the DM is attached as per the ASOCT. try achieve a single bubble. Even if you can't, it is fine. Just inject till you have a near complete airfill of the anterior chamber. So now you have this, you maintain the patient in this, you see the DM is attached. Now, after about 15 or 20 minutes of complete airfill, slowly release the air, form the anterior chamber with BSS and leave this air bubble of around 8 and 8.5 millimeters. So this is after 4 hours, the air bubble has gone down, the DM is attached on slit section. The AIOCT also shows that the DM is now attached. This is after 6 days, the cornea is almost completely cleared, the patient has regained useful vision. This is how they started off with. So this is another video in which this patient had undergone a phaco trab elsewhere, the trab had failed. So you can see the inferior PI, the superior PI and the striate keratopathy. So you just inject it below it about maybe 5 o'clock and then suture the side port. Leave the air bubble as it is. Once it is attached, you can reduce it after about 20 minutes of show. Thank you, Aditi, for sharing this video. So I'll go to my video next. So this patient had undergone a combined VR surgery in which they had done a phaco and vitrectomy in the posterior segment. So patient presented with this diffuse striate keratopathy. I'm sorry, I don't have the AIOCT image. But on the slit lamp section, you can make that something is amiss behind in the endothelial level. So he had undergone a trial of desmetopexy elsewhere and then referred back to me. So basically, this is the tractional kind of DMD in which you have to inject air into the suture, the side ports, and I have gone with a reverse cystitome, and then you have to release the traction on the desmet membrane, again refill it with air. See that the traction is completely released by giving those nicks, relaxing incisions in the DM with the bent cystitome, the 26 gauge needle. So once you release that, you know that the air is going to stay and the DM is going to stick. So if you don't release the fibrotic DM, the adhesions, it won't work. So no amount of airfill can actually help. So this is immediately after the complete airfill. So you can see the corrugations, the folds in the DM. This is after 1 week of desmetopexy, that is rather desmetotomy, in which now the DM is completely attached. And should you bother with injecting again if the first attempt fails? Yes, this Dr. Jain's paper from LVP has included 13 eyes who underwent a repeat desmetopexy. And the results is that it's worth a second chance before you declare the case for a EK or a PK or you refer it to your corneal colleagues. So the take clinic message is it's not so uncommon, it's a sight-threatening disorder if you don't recognize it and manage it on time. Watch out for dystrophies before you do cataract surgeries. Always use sharp instruments, good incisions. If the persistent corneal edema is present, always suspect DMD, rule it out by AIOCT. And you have to customize the management as per the case and refer on time if you are still in doubt. Thank you so much.
Next, we have our moderator, Dr. Swapnil, who will be talking to us on simple surgical techniques to improve the ocular surface. We apologize to the next session. We've got the hall a bit late, so we are trying our best to cut short the talks.
Our session had also been delayed over 20 minutes, so.
It's not connected yet. So in the interest of time, I'll just cut short my topic and talk whatever is relevant to maybe general ophthalmologist. So my topic is about how to improve ocular surface with common surgical procedures. And oh, it's there already. I can't see it here. Excuse me, can you please help? It's locked. नहीं हो रहा है कुछ भी हाँ हो रहा है चलो that's fine so I'll just quickly mention the procedures which are done to improve ocular surface commonly. commonly. So usually we do procedures to treat the severe dry eye, lid viper keratopathy, as we mentioned. So we get a minor salivary gland transplant for severe dry eye. We do lid margin MMG for lid viper keratopathy. This is a very useful procedure doing conjunctival flaps for painful bullous keratopathy, which many of the general ophthalmologists usually see in your OPD. And third is limbal stem cell deficiency, where we do limbal stem cell transplant. So coming on to the procedure, I'll just show the most commonly done procedure by general ophthalmologist, and you should be able to do this. So whenever we see any painful blind eyes, this is the procedure I think you should all learn. So it is nothing but doing like taking a graft like a pterygium surgery. Only thing is there are some variations. So you have to mark the graft superiorly, and then you have to take a similarly like you do for pterygium graft, try to take only conjunctiva and try to avoid tenons. And you have to mark along the limbus as well as posterior as possible, and then go along the limbus towards the temporal and nasal side. So this is how, and try to avoid the tenons because this is quite a large area we are excising, and then it might form the granuloma unless you apply an AMG. So try to be as superficial as possible and avoid tenons. And again, try to excise at limbus as far as possible because usually these eyes have scarred conjunctiva, and then go towards the nasal and temporal side so that you can create a pedicle. Once you create a pedicle on both sides, try to make the free flaps on both sides so that you would be easily able to slide the conjunctiva and the cornea. So just depithelize all the cornea. And once you do that, you have to just check whether, all the flap, before applying the glue, whether the flap is really fitting onto the cornea. There is no traction on either side. And once you reposit the flap properly on the cornea, then you can do one by one. You can just lift the superior part, put the fibrin glue over that, and you can use separately or you can use combine both fibrin glue, and just try to iron out the graft over the cornea. Similar procedure you have to repeat on the inferior side. Sometimes you can apply sutures. I would prefer, I usually apply circumferential 10-0 nylon sutures because sometimes grafts tend to retract and you can remove it after maybe 3 to 4 weeks. So this is how I apply at both the ends so that it will not slide. Both the ends I apply 10-0 nylon sutures. Believe me, this is one procedure which really do magic for the patients usually who come from rural area, and we cannot really give them very fancy options. So sometimes it is a complicated anterior segment and we really can't do anything for them, and they just keep on coming with irritation, pain, watering. And if we do simple procedure and the final outcome would be something like this. And if we do this simple procedure, which anyone here sitting here can do, that would make them really, really comfortable throughout their life. And sometimes they are really not bothered about vision and all those issues, and what they need is just symptom-free eye. In the interest of time, I will skip the next salivary gland transplant video, but I would just show the overview of the salivary gland transplant. What we do, this is our technique by Cyan and us. So what we do, we take the minor salivary glands, which is nothing but the submucosal glands throughout the oral cavity. We take the minor salivary gland mucosa complex, and we suture that complex superiorly onto the suprarectus muscle so that it gets the direct blood supply from there. Usually the secretions are spontaneous, and once we place salivary glands over there, they start getting vascularized, and we can get the good result. So like in this patient, you can see the salivary gland is placed superiorly. It got vascularized at 3 months nicely, and that is 4 years outcome, and there are still functioning salivary glands. And the the patient who is not even able to open the eye, you can see I can easily take the slit lamp photographs, and the eye is relatively wet and they are symptomatically better. Similarly, there are many patients who benefit, severe patients. Obviously, we have to keep the limited expectations from our side and do whatever best we can do for this patient. This was the salivary gland transplant with slit, and you can see patient is at least ambulatory now. And this is SJS patient. This is again SJS patient with severe dry eye. After salivary gland transplant, you can see the relatively wet eye. Similarly, we have a procedure. This is a paper which we published in BGO about salivary gland transplant. You can read that paper to know about it. And this is a classical case where over a period of time there is decreasing scarring after salivary gland transplant, and this is how it is helpful for this blinding in these blinding diseases. And the third procedure we all know is, as Purvasha showed, there is a lot of lid margin keratinization in these HJS patients. And what we do is in this lid margin keratinization, or we call as lid viper keratopathy, we just replace the lid margin with mucous membrane. I think I'll skip the video because we are really short of time, and I'll have to wind up. This is one procedure where you just replace the lid margin with MMG, and these patients, it again really works wonder. On the first day itself, you can see that they can open their eyes nicely. It's like foreign body in the eye, and once they get rid of it, they just open their eyes, and it really works wonder. This is another patient, and you can see this. On the left side, there is a lot of keratin. On the right side, I have done the MMG, and I have achieved the smooth surface. And for this girl, it has really worked wonder. This is a day 3 photograph. Can you imagine the change in the quality of life? So thank you so much. And sorry, I really couldn't present the whole talk because of lack of time. I would invite Dr. Kunjal to talk about. Dr. Kunjal is an ocular surface disease specialist. She practices in Mumbai. And
at the outset, I'd like to thank the organizers of the session for making me a part of this wonderful symposium. I'll be talking on corneal tattooing. उसमें नहीं आ रहा है कर दो ना. So when a patient with a disfigured eye like this comes to your OPD asking for better cosmesis, the options are a prosthetic contact lens or corneal tattooing or evisceration and ball implant, the latter being a very radical procedure and not accepted by many patients. So what is the advantage of giving a prosthetic lens? It's basically non-invasive, very easy to wear and remove whenever the patient desires to, but it requires compliance and there are hygiene issues. Corneal tattoo, on the other hand, is an invasive procedure. However, the most important point is that when the opacity, when the patient does not wear the lens, the opacity is going to be visible, and hence corneal tattoo is more like a permanent procedure and hence preferred. So any patient in a non-seeing eye who presents to you with a corneal opacity or corneal edema after a failed graft with poor prognosis for a repeat graft or decompensated corneas because of silicone oil after VR surgery, leukochorias like pupillary membranes or complicated cataracts, iris defects, and large peripheral iridectomies in which it acts as a therapeutic indication if the patient has a lot of glare and diplopia. So the technique which was described, the most ancient technique, is actually the chemical method in which pigments like gold chloride and platinum chloride are used along with fixative agents like hydrazine hydrate. Then came the coloring methods. This can be done with the help of commercially available powders from, like, say, the Mahatme powder, or preparing a carbon suit in the operation theatre with the help of a candle or India ink or any tattoo dye which is used for the skin tattooing. So the techniques of application are superficial application of the pigments or transepithelial intrastromal micropunctures with the help of a 30 gauge needle. However, this does not work very well, it doesn't last. Intrastromal lamellar pocket technique works extremely well. You can make the pocket either by the manual technique or with the help of a microkeratome, or even a femtosecond laser can be used, and the use of a tattoo gun. So this is a video of a lamellar pocket technique. What you do is make a very superficial incision, and then using your crescent knife and your lamellar dissectors, you make a very superficial pocket. Make sure that the pocket is very superficial so that not much of the opacity is going to be seen over your flap. You can use any liquid dye or soot or any powder and use your dissector or an iris depositor to put it inside the pocket. If you have a limbus to limbus opacity, then you can do it just as you do your manual dissection and desec by using the specialized dissectors. After you do this, supposing you feel that there's some opacity over your flap, then just use the needle to do micropunctures, and if required, you can suture the incision. So this is a patient with post-VR surgery, and this is a picture 6 weeks post-op. Here the tattoo powder was used. In this patient, this is a 2.5 years follow-up. Here the carbon suit was used. This is a patient post-VR surgery. I debrided all this and there was a edematous cornea underneath. I tried to achieve a brown shade for the iris and a central black pupil by using the liquid dye. We next come to the tattoo dye technique. I thank Dr. Aditya Pradhan for introducing us to this technique and helping us get this machine from China. However, we have some brands available in India too. This is basically the assembly with the adapter, and this is a tattoo gun, and there's a disposable needle which has to be placed on it. Here you have to go on to and come to the eye settings and then adjust the speed of the needle, attach the needle here, and then adjust the depth of the needle. You can use any commercially available liquid tattoo dyes, but this brand somehow works very well. After you debride the epithelium, just place a tiny drop of the tattoo dye on the surface. Check the movement of the needle before you start the procedure, and just use it in a line, like a little bit of a angulated manner, so that you're not very deep into the cornea. And this movement just helps to impregnate the dye into the stroma. And you just wash this off with saline, and then just repeat this procedure 3 to 4 times until you're happy with the outcome. And then just place a BCL at the end of the procedure. So this is a patient with a lot of spheroidal degeneration. I did a debridement, used EDTA to remove the band-shaped keratopathy, and used this tattoo gun, and this is the outcome. This was a patient with a complicated cataract post CRVO, and I used the same procedure for him. This is another patient with a post-VR surgery. Similar case. This is a young child with 2 failed grafts and advanced glaucoma. This was a patient with a pupillary membrane. So we then come to the surface application of chemicals. Actually, this was the oldest technique which was described. However, I shifted to it the most lately. You can use gold chloride and platinum chloride. These are commercially available. The gold chloride concentration can be 2 to 5%, and platinum is preferred for 2%. You have to reconstitute them in distilled water and refrigerate. And whenever you want to use it for your surgery, you have to autoclave them. Even hydrazine hydrate is available commercially. You just have to make sure that your dilutions are right. So you debride the epithelium, and then you can use either a gauze piece or a filter paper, like a Wattman filter paper, or I just prefer to use this ring to hold the dye. Just put a few drops, wait for a minute, then you put your hydrazine hydrate, and then you get your desired color. Platinum chloride gives a jet black color, and gold chloride gives a brownish color. After washing, you can repeat the procedure. I'm just using a Trifine here, so that just to show you what all you can use to hold the dye. Just make sure this doesn't spill onto the conjunctiva. I wanted to give it a slight brown color, so I'm applying gold chloride here, followed by hydrazine hydrate, and then application of a BCL. So this is a patient 1.5 years post-operatively, again post-VR surgery. You can see that there's a slight fainting of the dye. However, on external appearance is very good. Another patient with the same condition, you can see the brownish shade of the gold chloride powder here. So the complications are loss of tattoo color. This should be expected in 10 to 15% patients. Persistent epithelial defect can be seen in a few patients, so I prefer to put the BCL for at least a month. Some patients have a persistent congestion and an inflamed eye, and they need topical steroids for a longer time. Basically, we give topical steroids, antibiotic and lubricating eye drops for a month, and recurrent corneal erosions are very rare. These are a couple of patients with the loss of the tattoo dye, with the liquid tattoo dye, and this was a patient in which the surface application of chemical agents was used, and the patient had a persistent epithelial defect and a very early loss of this color. This was a patient very recently done, and she had a little bit of an edema, corneal edema, and few DM folds, so I had to hike up the steroids. So in summary, corneal tattoo is an excellent cosmetic option for disfigured eyes. The surgical techniques are evolving and they do give good results. However, one has to counsel the patient about the possibility of repeat surgery, and one should avoid vascularized corneas because they definitely have a very early loss of pigmentation. And some patients with silicone oil in the eye, post-retinal surgeries, they also have early loss of pigmentation. Thank you for your kind attention.
Thank you, Dr. Kunjal. Next talk is by Dr. Vinith, and he is going to talk about tricky corneas. So we'll come to know what he exactly means by tricky corneas.
Thank you. So basically, in tricky corneas, I'll be just covering how to manage cataract surgery in cases which you don't want to see and which ones you refer to cornea practitioners, but you can actually manage at your places. So to just give you some tricks regarding the same, and I'll be quick with just a few videos. So it's okay. So basically, in a traumatic cataract after corneal tear repair, if you have if you're planning for a lens aspiration, there are certain things, because it's a complex anterior segment case, it will have a lot of pus, it will have posterior synechiae. So basically what you can do here is basically make space. So you have to release both the anterior synechiae as well as the posterior synechiae, but always use trypan blue. These cases are possible. You can use the micro scissors and micro forceps. They are the very useful instruments here. Now you can see that the pus is actually formed. It's quite thick and intense. You can't pass through and through with it. So use the micro scissors to open it up, open the anterior chamber, make space for it. So once that is done, you go behind and release the posterior synechiae. So all this has to be done in OVD. That's why you have to first inject blue with whatever area it can stain. Since the scar is in the visual axis, it's difficult to visualize what is behind. But you can open up the posterior synechiae using the blunt instruments. But there is another problem here, that it's not just a posterior synechiae, but the bag itself has a plaque when it is attached to the corneal scar. So sometimes it can be so thick. Here I am trying to do using the anterior vitrector, it doesn't open up. So what you can do is you can take an MVR blade and actually make a punch hole through it, and then through that hole use the anterior vitrector to open up and do a posterior capsular rhexis kind of thing. But in this case, even that was not possible. So I actually used the micro scissor only to cut the posterior capsular plaque, and it was as hard as a stone. It was an absorbed cataract. And once that was done, through the main incision, we just removed it. Now we are doing anterior vitrector. This is the most important tool in these complex cases. We have to just open up the visual axis. So clear off the center as much as you can. You can do a optical iridectomy within the same using the anterior vitrector, and clear off the fibrous posterior capsule and the absorbed cataract using the same thing. Just be careful that it doesn't, fragments of the cataract does not fall into the posterior cavity. Once that is done, the good sign is the red glow. Once you start seeing the red glow, you're in the right direction. And once you have made the sulcus by releasing the posterior synechiae, now all you have to do is fit in the 3-piece lens in the correct orientation where you will not come across any synechiae. Now this is a little tricky part, because sometimes when you try to push it from one side, it will come out through the other side. So you have to just adjust a little bit, and after that do a thorough anterior vitrectomy. That also creates certain amount of space, and eventually it does well. So it looks complicated in the beginning, but this patient ended up having 20/80 vision improving to 20/50. So another similar case like this was a case of microbial keratitis. We did Tenon's patch graft and all. There is almost a large inferior scar with vascularization. Again, same concept, use trypan blue to stain, and here we tried to break the pus, but it started bleeding. And in this case, we tried to use phenocane, but there was no dilatation here. As you can see, it was a very large pus. So we have to do a blind rhexis, or you can do envelope technique or a capsulotomy. So basically, the whole idea is to get the nucleus out and maintain the sulcus. The size of the shape of the rhexis would not matter much. So here, that's what exactly I tried to do. The space in anterior chamber was less, so I tried to remove the nucleus in that particular direction itself. Once the nucleus is out, the procedure is same. So the idea is usually you put the ACM at the 6 o'clock, but because of the past, we have to put it in this position. Again, here the aim is to remove as much as cortex as possible and to get a good red glow. Once you get the red glow, that is a sign that you can now go for optical iodectomy using anterior vitrector, or if you are seeing a PC plaque, you can do a PCC along with it. But here the sulcus was quite good enough, and we ended up putting a PMMA lens. The patient did well. Certain cases are like patients have smaller tears, smaller scars, but they end up having a large traumatic cataract. So we had to remove the cataract during the first corneal tear procedure itself. So what happened was there was a rip in the anterior capsule, and both anterior capsule and posterior capsule fused to each other. So now we had to put OVD through this gap and create artificial rhexis using the micro forceps. And that's where I say these instruments, always keep them in your armamentarium. They really increase your chances of doing these complex cases. And once we fashioned the pseudorhexis on both the sides, the regular hydrophilic foldable lens was put in that direction. The only complication here was in that at the 6 o'clock where the scar is, both AC
Dr.
and
Vineet,
PCs
can we
were
wind up?
fused. Yes.
Yeah.
So in that case, I just wanted to highlight that some of these, I had a collection of other microcornea and spherophakia cases, but to point out these complex cases can be managed at comprehensive level as well. Thank you.
Thank you, everyone. We couldn't do really justice because of time, but we tried whatever we can. Thank you so much again. And sorry we took your time.
I apologize to the Cornea people. I am trying to cut down our session also time and discussion, because I don't want the chain casket to continue and the whole session goes late. And I wouldn't like anybody to cancel their talks, which you were telling, no, it is not possible. So without wasting time, you'll take the photograph till Sushma is there. Yes.
First is Dr. Parag. Okay. So very good afternoon. I'm sorry I have to make this announcement because in interest of time,